Okay, thank you, Prof. Suhendra, for the opening speech. Then we move to the next opening speech from the Dean of Faculty of Medicine, Universitas Indonesia, Professor Dr. Ari Fahril Syam. To Prof. Ari, the time is yours. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all.
Good morning.
Yeah, our distinguished guest, Professor Dr. Michael Freeman, Ph.D. MPH, Associate Professor of Forensic Medicine and Epidemiology, Maastricht University Medical Center, Netherlands, and also the moderator for guest lecture this morning, Dr. Putri Dianita, and also Professor Suhendro, and Dr. Harina as chairman, and also the secretary of our study program for PhD, Faculty of Medicine, Universitas Indonesia. I, as the Dean of Faculty of Medicine, would like to extend my warmest welcome to all participants, and especially today's guest lecture, Professor Michael Freeman from Maastricht University Medical Center. This is just a great pleasure for us to join us virtually this morning. Today's lecture that Professor Hendro mentioned will bring up the topics of the role of epidemiology in evidence-based forensic investigations of that injury. I think this is the important topics, especially for forensic medicine. I hope that we can continue collaborations between UI and also Maastricht University, not only for guest lecture, something like this, but also to make research collaborations in the future. Yes, we are very fortunate because today we will have the opportunity to discuss regarding the issue with the Professor Michael. Hopefully what we will learn today will not only benefit our knowledge, I think, and also I think for not only for the PhD student here who attend this guest lectures, but also for our staff, especially in the forensic and medical legal department of Faculty of Medicine. Again, I would like to give my appreciations to all committee members who have taken part in today's guest lectures. And again, I would like to deliver my sincerest gratitude to Professor Michael that has given his time to share his knowledge with us. I think we cannot wait to hear more of your insight and ideas in person after this COVID-19 pandemic ends. Finally, I hope that everyone who gathers here can take benefit from today's discussions. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Prof. Ari, for the speech. Next, to all participants, we will take a photograph. Professor, Doctor, please turn your video camera on. Okay, are everybody ready? Pak Yana, please take picture.
One, two, three. Again. One, two, three. Yes, thank you.
Okay, thank you. Then we move to the main of this agenda, lecture from Professor Dr. Michael D. Freeman, and I will turn over this event to Dr. Putri Dianita Ika Meilia as moderator. Dr. Putri Dianita Ika Meilia was born in Jakarta. She graduated from the Forensic and Medical Legal Specialist Education Program of the Faculty of Medicine, Universitas Indonesia in 2010. And she took a master's degree in clinical research methods at Monash University, Melbourne, Australia in 2015. She pursued a doctoral degree in the field of forensic epidemiology at Maastricht University, Netherlands, and also in the Universitas Indonesia at the same time. She is still struggling to finish both programs while fulfilling her main task as a head of the Forensic and Medicolegal Medical Staff Group at Rumah Sakit Persahabatan, Jakarta, Indonesia. To Dr. Putri, please take over this program. Thank you.
Thank you, Dr. Anna. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Welcome to today's guest lecture with the topic, The Role of Epidemiology in Evidence-Based Forensic Investigation of Death and Injury. We are pleased to have you join us and take part in today's session. In order to be considerate and respectful to our speaker and everyone attending today, all attendees are muted. But don't worry, we will have time for discussion after the presentation. And you may submit questions at any time during the session using the chat feature. I will always monitor the chat feature. To facilitate discussion, questions should be asked in English, but if you're not sure, you can also type in Indonesian and I will translate for you. And now I'm pleased to introduce Prof. Michael D. Freeman, who has joined us today from halfway across the globe. Good afternoon, Prof. Freeman. How are you?
I'm very well, thank you.
Good. I hope everything is good, all things considered. Okay, let me
As best
just.
as we can be doing.
Yeah, we're just holding on, I guess. Okay, let me just quickly read your CV. I think it'll take me 10 minutes to do this. So, okay, Prof. Michael Freeman is a tenured professor of forensic medicine and epidemiology at Maastricht University Medical Center, and a joint professor of psychiatry and epidemiology at Oregon Health and Science University School of Medicine in the US. He serves as an affiliate medical examiner with the Allegheny, am I saying that correct? Allegheny County Medical Examiner's Office in Pittsburgh, PA. Not quite sure what state that is.
Pennsylvania.
Okay, Pennsylvania, right. And is a fellow of the American College of Epidemiology and the American Academy of Forensic Sciences. Dr. Freeman is a recent Fulbright Fellow with the US Department of State in the area of forensic medicine and holds a diploma of legal medicine with the Royal College of Medicine in the United Kingdom. Prof. Freeman has published around 220 scientific papers, books, and book chapters, primarily focusing on issues relating to forensic applications of epidemiology in general and specific causation. We'll also later find out more about what general and specific causation is. He has published research on the topics of traffic crash-related injury and death, injury biomechanics, injury causation, genocide, cancer epidemiology, chronic pain mechanisms, and adult autologous stem cell therapy, among others. So that's a lot of ground to cover. And Prof. Freeman is the co-editor and co-author of the authoritative text on forensic applications of epidemiology, which is Forensic Epidemiology Principles and Practice, which was published in 2016. As a consultant in forensic medicine for more than 20 years, Professor Freeman has provided expert testimony more than 1,200 times in a wide variety of civil and criminal cases, including injury, death litigation, automotive and other product liability, toxic tort litigation, life expectancy, and medical negligence cases, as well as in homicide, assault, and other criminal matters. And Dr. Freeman holds 6 university degrees, so I have a lot to catch up with him, including a Doctor of Medicine degree from Umeå University in Sweden, and a Ph.D. and Master's in Public Health and Epidemiology from Oregon State University, inter alia. So he has completed a 2-year fellowship in forensic pathology through Umeå University and the Allegheny County Office of the Medical Examiner. Phew, that's it, your CV. And now we will tune into your lecture. If you could start screen sharing. Yep. Okay, time is all yours, Michael.
Thank you. Thank you, Dr. Putri, for that very nice introduction that unfortunately I wrote, but you read it very nicely. And for the very warm welcome from everybody. I really appreciate it. And I'm truly delighted to be chatting with you all here. And I'm sorry that we can't be in person, but maybe someday I'll get a chance to come and see your beautiful country. So I'll just sort of jump into it. Epidemiology is something that, well, you really can't turn around without seeing somebody talking about what an epidemiologist is saying because of the COVID pandemic. It's basically described by epidemiology and epidemiologists. But we really don't think of it in the context of forensic medicine unless you think about how epidemiology is used to investigate outbreaks. So there might be an outbreak of a bloodborne illness or an infectious disease. Even there can be a potential outbreak of a terrorist attack, for example, an anthrax attack. Those are all investigated using epidemiologic methods, but we really don't think about that very much. Forensic epidemiology is the application of epidemiologic ideas and concepts and terms, but it's really applied very much in a forensic medicine environment. And hopefully I'll make that fairly clear how all of those things interrelate. As some of you may or may not know, since we're talking about forensic epidemiology and forensic medicine, ultimately, the term forensic came from the death of Julius Caesar. I'm not sure if this sounds familiar to anybody or not, but Caesar was stabbed to death by a number of Roman senators who essentially wanted to execute him as an act of the state rather than as an individual act. And so I guess they all got together and stabbed the poor guy to death. The idea behind it was that they would not be individually responsible for it, but what happened was that there was a Roman physician who was named Antistius, who said that he could actually tell which of the stabs were the ones that killed Caesar, which that's not unreasonable, but also he could tell who it was who delivered that fatal blow. Not so likely, actually, but he was about to give his evidence in front of the Roman Senate, which sat in this group of buildings that you're looking at here, which was the Roman Forum. Although, from what I understand, he was not able to give that testimony because war broke out. The term forensic sort of got stuck with giving evidence in front of fact finders or someone who's going to make a judgment, judges, juries, which we have in the United States. I'm not sure if you have many juries or if all of your judicial actions are decided by judges. In the United States, in Europe, Indonesia, other countries around the world, the forum that we talk about now is a courtroom. That is where evidence is given. Now, there's something that is very intoxicating, if you will, to a lot of experts when they're given free rein to opine about what they think about in a murder case, for example. And some folks get sort of carried away with their own importance or they get sloppy with their methods. And so what we have found over the past 10, 15 years is more and more close examination of techniques that at one time we thought were really reliable and we're finding out really aren't that reliable. And an example here you can see is the use of bite marks as a means of identifying individuals who may be culpable for a crime. In the United States, we had a number of unsafe convictions that were reversed as a result of finding out that bite mark testimony was essentially invented by one guy and that he really wasn't very good at what he was doing, but he was selling it in a very convincing way. this whole concept that courts need to be given information that is reliable, and if they're not, then there is a much greater risk that a miscarriage of justice may take place, has focused attention on this concept of evidence-based medicine, evidence-based practice in forensic medicine. Generally, we think of evidence-based practices as being medical practice that incorporates research, good research, into practice, that there is a reason for why a particular treatment is provided in the context of what we know from valid published research. This is something that we don't think of as much, but the use of such evidence base allows us to consistently reproduce the same results. And one of the things that we want to do in forensic medicine is say, you know, if I give these tools to anybody, they're going to come up with the exact same outcome that I came up with. That there is less of, I have many years of practice, and therefore you should believe me because I have done this a lot. And more of, everybody can pick this up once they learn the technique, and they should come to the same result. So we tend to think of forensic sciences that work in conjunction with forensic medicine as things like gas chromatography, evaluation of samples for certain toxins. This is something that we can reliably replicate as long as we do the same thing every single time, because it's all done in a machine. It's like a DNA testing, where we're looking for DNA profiles. If we have good samples and the samples are reliably acquired, the actual testing that tells us what whose DNA we're looking at should be reliably reproduced by anybody who uses the same technology. Or fingerprints, for example. It's another example of such technology that should be reliably reproduced. Now we get to this sort of gray area that is an important part of what goes on in courts. It is information that comes typically from medical experts, forensic medical experts, but it's information which can be very highly variable in how it's derived. And so it may have a relatively low rate of reliability or reproducibility. And that has to do with causation. Dr. Putri talked about the concept of specific and general causation, meaning essentially general causation being questions like, does smoking cigarettes cause lung cancer? That's a general causation question. A specific causation question is more directed at what happened in an individual. Did this person smoking cause their lung cancer? Is a specific causation question. In any kind of a case that is going to be heard in a court, there are certain elements that must be presented. The first element is that there must be evidence of harm. In a homicide case, we have to show how somebody died. What was the actual specific mechanism that produced the death? We find somebody with a stab wound. We do an autopsy and we find that they have a pierced left ventricle. We say, well, they died of hemorrhagic shock because they bled out very quickly. We also have to have evidence of a wrongful action to the person who has been charged with a crime or been found, or is accused, I should say, of being negligent, doing something improperly that may have caused a death or an injury. You can have harm that may be due to an action that's committed, a traffic crash. That's a negligent action. If somebody is on their cell phone and they run into another car, cause an injury or a death. It can also be due to an omitted action. The failure to diagnose a condition that can easily be treated may lead to a charge of negligence in medical care. But the thing that connects those two, the injury or harm, and the action that we think may have caused the injury or harm, is causation. Causation is the thing that puts those two together. It links the two. Now, courts require, generally, around the globe, that experts testify to some degree of probability, that you believe that your opinion is more likely than not. It may be to a very high level. For example, some courts require that testimony be given to a reasonable degree of medical certainty. It turns out we don't actually know what that means. So, for example, there was a National Commission on Forensic Science in the United States that was convened based in part on the problems with bite mark testimony, which we were talking about earlier, and some other problems with poor standards in forensic science and not so much forensic medicine. And actually it had come through testimony that was given by the FBI in the United States and out of some jurisdictions. But what this commission, this national commission, came to a conclusion was that the idea of reasonable certainty is you can see this term here, it's idiosyncratic to the witness. It's whatever I think it is. And therefore, when I say to a reasonable degree of medical certainty and someone else says it, it may be two different things in our own minds because we really don't know what it means exactly. This is a problem, obviously, because when one expert can testify to something as a reasonable degree of medical certainty, and another expert says, no, I can't, and it's the exact same testimony, now we have personalities getting involved, and we don't know how reliable that is. So how does that create problems if we're talking about causation? Well, it has to do with the fact that causation is not something that we can see. And this is a very important concept to understand. You can see a diagnosis. You can see a lab test. That's something we can all agree is something that is something that is true. But you can't see a cause. A cause is always an inference. It's something where in my own mind, I've put two and two together and I've come up with an answer. So, for example, here's a diagnosis. What's the diagnosis? Well, a 5-year-old child could look at the x-ray on the left and say, that person has a broken leg. That's very obvious. And it doesn't look like a normal leg like the one on the right. That's an observation. And we're not going to argue about that. But if I tell you, for example, that person was involved in a crash at an intersection where two impacts happened. They went through and the first crash happened where they were in a big frontal crash and then they were hit from the side. And we want to find out which of the two crashes caused the injury. That's not something you can see on the x-ray, and it's not something you can see by looking at the crash. The way we tell the difference is by saying, well, we looked at 1,000 crashes like the one on the left over here, and we found out that people get broken legs 10 times more often than they do in this crash on the right. And then we can say, well, I can't say I know for sure which crash it was, but it's 10 times more likely to be the crash on the left. That's a probability of cause, but it's not an observed cause. It's an inference. Now, that comparison that I just made had to do with risk. What's the risk of a broken leg from one crash versus a risk from another crash, both of which happened around the same time? So if I ask you, for example, who's more likely between these two gentlemen to have a heart attack tomorrow? And so the man over here on the left, he's from Indonesia and he's in very good shape. And the man on the right, unfortunately, he's probably from the United States, not in such good shape. we have a pretty good idea of who we think is going to be having a heart attack. It's going to be the guy on the right because of what we know about people like him, not him. In other words, he hasn't had a heart attack. We don't have to know anything about him other than what his characteristics predict. Well, that information comes from epidemiologic study because risk comes from epidemiologic study. I'm sure everybody knows what epidemiology is, but I'll give you a very quick definition. It's just the study of populations with similar characteristics: injury, disease, exposure. What we look for from epidemiologic study is going to be either distribution, the 3 Ds, distribution, determinants like risk factors, or deterrents, things that prevent injury or disease. You will be able to see, if you think about it, that concepts of epidemiology associated with risk are woven into virtually every causation opinion that you'll ever see in a court. Now, all right, this guy, he has a gunshot wound to the middle of his head. And you can't see it, but at the back of his head, he has a very large wound, and he was killed instantly after the gunshot. I'm not talking about using epidemiology as a way of understanding what happened to this person. However, you'll also grasp that the reason we think the gunshot wound killed this man is because if you get shot in the head, there is a more than 90% chance that you will die. That is a very high case fatality rate, being shot in the head. And the chance that he was going to die at the same time from anything else, exactly at the same time he was getting shot in the head, is incredibly small. But maybe he's also got a stab wound in his chest. And now we have to decide, was it the stab wound from one guy or was it the gunshot from the other guy? Was he for sure going to die from the gunshot wound? So at a certain point in time, you can start to come up with scenarios where understanding the risk of the death from the event is important for making the comparison. This creates problems, of course, because when we talk about individual causation or specific causation, that comes from clinicians, forensic medical clinicians, or physicians who examine people and treat them. That's who talks about individual causation most often, someone who examined the person and made the diagnosis. But if we have to use risk to assess causation, because there's a comparison made, like the man who got the broken leg in the car crashes, it comes from epidemiology. And epidemiology doesn't look at individuals. So in order to say something about a comparison of risk, we have to look at a bunch of people. But if we look at a bunch of people, the expertise that does that usually doesn't look at individuals. Compound with this the concept that what I'm telling you right now may be very new to a lot of you. It may be new to all of you. The idea that causation or causality is really based on a comparison of risk is something that we don't really hear very much. And how to go about comparing risks and in order to analyze causation in an individual is actually something we don't really learn in medical school. We don't even learn it in forensic pathology fellowship and residency. So this practice of forensic epidemiology is how do we bring epidemiology together with forensic medicine to try to understand, to add to our understanding of specific causation. And this is the area that in which I teach, and I have a Ph.D. program with a number of Ph.D. students, and have the great pleasure of having Dr. Putri as my very first student, going back almost 5 years now. And I think I've learned as much from her as she's learned from me. So it's been a very nice collaboration. But what we're trying to do is really spread this concept of epidemiology as a basis for evidence-based practice. So I want to talk to you about 5 different investigations The first one is a specific death of a child who was attributed to physical abuse by a parent. The second one is a suicide of a teenager who took a drug that was misdispensed that he should not have taken. The next one is excited delirium as a cause of death in the presence of forceful restraint. And I'll hopefully be more clear about that in a little bit. The next is crash-related head injury, and the last one is neonatal falls occurring in the hospital. All of these analyses involve the application of epidemiology to specific causation, and they're all very different. But what I want to do is help you understand some of the methods that are used in the forensic epidemiologic analysis of these kinds of issues so that you can get a feeling for it. So let's start with abusive head trauma. This is something that is given various terms in various parts of the world, but a lot of you may be familiar with the term shaken baby syndrome. The idea that without a hard impact to the head, a shaken child can sustain bleeding in the brain as a consequence of abusive shaking. The diagnosis has been described in the literature as being part of a triad, meaning that it results from the finding of often three types of diagnoses in the brain and the head. First is intracranial hemorrhage, most often subdural subarachnoid hemorrhage, retinal hemorrhage, bleeding in the retina, and edema in the brain, which is really a consequence of the first one, the intracranial hemorrhage. This is a very unusual form of diagnosis because the diagnosis, the finding of the intracranial hemorrhage, retinal hemorrhage and edema, is equated with a mechanism. In other words, when the finding of the injury is present, there is a natural inference that we know what caused this, it is shaking, and that the shaking must have been intentional, and therefore it becomes shaken baby syndrome, in that it is a form of abusive head trauma. There's nothing else in medicine where we look at a diagnosis and immediately know what the intent of it was. Even a gunshot wound, which has to have come from a gun, we don't know why the person pulled the trigger or necessarily even who. Sometimes the diagnosis is based only on the finding of intracranial hemorrhage with none of the other findings. So just to quickly give you a little bit of a background on this. So the subdural hematoma is the most common form of bleeding, which occurs when there is shear between the brain and the skull, basically, or the dura, so that the what's called bridging vessels bleed into the subdural space. Retinal hemorrhage are these little spots of hemorrhage that you can see if you use an oculoscope in the back of the eye. And then typically in a child who's seen in the hospital, although it can be seen also at autopsy, is the swelling of the brain, which sort of eliminates some of the folds, the gyri in the brain. So ICH, intracranial hemorrhage, when you find it in a deceased child and it is associated with fresh or old fractures or bruises that can't be explained, or we know that there is a history of abuse from a caregiver, a parent, this all goes together. It now becomes a mechanism by which a child might have to be admitted to a hospital or might be killed. What I'm referring to is not a child who's been battered who has intracranial hemorrhage or the triad. I'm talking about a child who only has intracranial hemorrhage or the triad and no other sign of abuse. The interesting thing is the way the triad is used is it treats the child with multiple injuries and obvious signs of abuse exactly the way it treats the child who has absolutely no history of abuse, but has an intracranial hemorrhage. Both of those children are assumed to have been abused in the way this diagnosis is used. So this is a condition or a trauma that was first described 150 years ago. It was popularized as shaken baby syndrome by a neurosurgeon named Norman Guthkelch, who later said that he was very sorry that he introduced this idea because there are so many claims now of people who have been convicted of abusing their children based on nothing more than the presence of the triad, and have been later found to have been innocent, even though they've been imprisoned. So abusive head trauma is this broad group of head injuries that may include a hard impact, whereas shaken baby syndrome has no hard impact. It's just the bleeding, it's just the triad. And you'll see that shaken baby syndrome has been written about much more often in the National Library of Medicine database. So in 2017, Linnu and Eriksson, Eriksson was my professor from Sweden, who I studied under forensic medicine, published a comprehensive review, a systematic review of all the literature on shaken baby syndrome. And when they got to the end, they said, there is no there, meaning there was no substance to it. It was all basically opinion. It was, we find the triad and therefore we think that it is abuse. And that there was no evidence base to say the triad equates to abuse. So what has come out of that and had been coming up into the literature before that time is these two camps. Basically the camp that is primarily pediatricians and abuse pediatricians who have the welfare of the child at heart, but who sort of leap to the conclusion if they find intracranial hemorrhage that must mean there has been abuse. And then there is a community of largely forensic pathologists and others in forensic medicine who said, wait a minute, we got to step back a bit here. So here are the assumptions. Intracranial hemorrhage only results from two mechanisms. And by the way, I'm referring to this as intracranial hemorrhage and not talking about the other two parts of the triad, because essentially retinal hemorrhage can result from any degree of intracranial hemorrhage, and so can cerebral edema. So those two things can go together and result from the very first thing, which is the bleed. So I'm really focusing on the bleeding. So the theory is that you can only get intracranial hemorrhage from either shaking as a parent or a caregiver, or if there is a huge amount of trauma, like the child is dropped out of a 2-story window, or there's a very high-speed traffic crash, and that nothing in between can cause the intracranial hemorrhage, which doesn't quite make sense. I mean, there are many parents who have said the kid was fine, fell out of my arms, he landed on a carpeted floor, and then he started getting kind of sleepy and then had a seizure, and the next thing you know, they're being accused of abuse because they're being told that it's impossible for the child to have sustained the injury. This is somewhat based on a myth. So the myth is that shortfalls cannot cause the injury. There's another sort of myth that goes along with this, which is that if a child starts to bleed, that loss of consciousness must occur right away. And there, whoever was the last person with the child must be the perpetrator of the abuse of shaking. So the forensic epidemiologic approach is to say, all right, that's fine. You have a theory. You say that you have the triad or intracranial hemorrhage, and that always identifies abusive head trauma unless there's some huge fall or traffic crash. So how good is that test? You have a test for abuse. How good is it? What is the true positive rate? How often does your test of finding intracranial hemorrhage or the triad, how often does that mean that there has been abuse? And more importantly, how often does it mean, is it wrong? How often is it a false positive? How often does it identify non-abusive head trauma as abuse? The term likelihood ratio, and of course I can't see anybody nod because I'm not talking to a bunch of people in front of me, which is always pretty tough, but some of you may be familiar with this concept of a likelihood ratio, just the true positive versus the false positive ratio. This is calculated from looking at epidemiologic data. That's where it must come from. It must come from populations. So the way the child abuse pediatric community has come at this is to basically say that if you have abusive head trauma, if you have the triad present, that's 100% accurate for abusive head trauma. And therefore, if the triad's absent, then we can say there probably hasn't been abusive head trauma, absent any other finding. But if we look at what the literature says, Lino and Erickson and others, we have no idea how often that's true. And that is a problem if you're accusing somebody of having committed abuse. I want to introduce one other idea that comes from epidemiology, which is this idea of a pretest probability, which goes to this concept that we were talking about earlier, which is if you have a child who has been extensively abused, and it's basically a battered child, and they have intracranial hemorrhage, versus a child with absolutely no evidence of abuse, but intracranial hemorrhage. How much does the presence or absence of the other information affect the test accuracy? So there's certainly evidence that we can say makes abuse more likely, but is there evidence that makes abuse less likely? So some of you may have seen this sort of nomogram type information where you start out with, oh shoot, what's going on here? Sorry. Where you start out with a pretest probability, and I'm going to show you over here. If we start out with the likelihood that somebody abused a child was, let's say, 50%, and then we have a likelihood ratio that we can draw the line through, the post-test probability of abuse, for example, can be increased or it can be decreased if we have a low likelihood ratio. But you have to have the data in order to be able to do that. So I'm going to tell you about a case where we used a likelihood ratio analysis and applied it to specific case facts. It was a 4-month-old baby boy who was found unresponsive by his father at home. The baby had the whole triad. He had the retinal hemorrhage, he had enough cerebral edema to cause a brainstem herniation, which caused his death. He had no other signs of trauma. There was no history of trauma or abuse. So the pediatric child abuse specialist, based on the presence of the triad, said, this is abusive head trauma. After 2 days, the child died. The father was charged with homicide. He was looking at, in the United States, about a 15 to 20 year prison sentence. Now, during the examination in the hospital, during the 2 days that the child survived, the child was found to have a factor 7 deficiency. That is, in the pathway of clotting, factor 7, one of the clotting factors, was found to be very, very low, or not completely absent, but just very low, which raised the potential for a coagulopathy, meaning that this child probably had a tendency to bleed. Well, that's a pretty important finding if you're talking about a child who ultimately died from bleeding in the brain, and whether or not that was a result of abuse. The pediatrician came up with kind of a crazy story who said that because the child had bled into the brain, that must have exhausted the clotting factor selectively, only factor 7, not the other clotting factors, which made no sense at all. Turned out the father also had factor VII deficiency, and the mother had prolonged clotting tests, and therefore there was a familial tendency to bleed in this little boy. Clearly, this would make the risk of spontaneous bleeding in the head more likely. Also, this child had no bruising, not a single bruise on his body. Why is that important? Well, if you've got a child who's more likely to bruise because he's got a factor VII deficiency and he has no bruises, that is a child who is much less likely to be abused because he's much more fragile. So the pediatrician, instead of looking at the actual science and evidence, said that this must have been due to abusive shaking that occurred immediately before the loss of consciousness, and that the only other cause was that it would be a high energy car crash or a fall, and therefore there was no history of the high energy crash. Thus, the injury must have been caused by the shaking. Well, we examined these myths. Is a loss of consciousness always immediate following trauma? What's the evidence? Well, the evidence is if you look at children who have hemophilia, that is a tendency to bleed, that when they have intracranial hemorrhage, in this particular study, 4 out of 6 children had no symptoms after a trauma for 24 hours up to 7 days. Okay, all right, so now it's not necessarily immediate. What else do we know? Well, we also know that children who have spontaneous intracranial hemorrhage are more likely to have coagulopathies. There was a study of children with hemophilia, 547 children less than 2 years old. They had 46 children who had intracranial hemorrhage. 18 of them were spontaneous and 11 were due to trauma. That means they just bled for no apparent reason. Well, that now becomes an alternative explanation for this child's bleeding, other than he was in a high-speed car crash. It becomes a complete explanation, in fact. The other factor is the lack of collateral signs of abuse. When you look at children who have abusive intracranial hemorrhage, if you examine them for other injuries, more than half of these children will have fractures. This child was pristine. He didn't even have a bruise. So as we drilled down to the specifics of this case, what we did was perform a specific epidemiologic analysis of US national hospital data from a very large database that covered, up to about 40 million hospitalizations per year, and was a very rich source of data from the US government. We pulled 15 years of data that were relevant around the time of this particular case, and we looked for presence of ICH, intracranial hemorrhage, and retinal hemorrhage together. We also looked for fractures and other signs of abuse that we could eliminate. Remember, we want to look at kids like this kid, so we find children who don't have other signs of abuse. All we want them to do is have intracranial hemorrhage and retinal hemorrhage, and they look to find out how often they had abuse. We also look for coagulopathy. This is a very interesting sort of finding that we came up with. We had a very large number of children to look at, almost 9,500, which gave us a very strong statistical basis for our analysis. So if we took all of the kids who had this condition, 53% didn't have any other injuries. So we now pared it down to 5,000 children with ICH and retinal hemorrhage. And what we found is that when there are no other injuries, abuse is diagnosed in 71% of the time. Here's the really interesting thing. And they were primarily shortfalls, the non-abused cases. Among children with coagulopathy, abuse was coded 79.2% of time. Now, why do you think that's interesting to me? Well, it's very unlikely that parents selectively abuse children with coagulopathy more often than they abuse children without coagulopathy. There's no reason for that to be the case. So it tells me that there's this excess between the non-coagulopathy cases and the coagulopathy cases of an additional about 9% or so. And maybe those are cases where it's just unexplained bleeding and somebody says, oh, that must be abuse. It's an interesting question to look at. Are we actually seeing the overdiagnosis of abuse when it's not present because it's actually explained better by the coagulopathy? But unfortunately, we weren't able to actually dig into that too much. What I was more interested in was this poor guy is being accused of abusing his child to death. So I developed likelihood ratios that could be applied to this case. If I looked at all of them, I came up with a likelihood ratio of 2.4 of true positive to false positive. And if I looked at just the coagulopathy group, it was 3.8. If I put that into this nomogram, what I can say is if I start at a 50% probability that of abuse, because we don't know the answer. So before we ever apply the test to these facts, and we say, well, there's a 50% chance he's either that he abused or didn't abuse, because we don't know which one it is. If we go through, well, that's not good, sorry. If we go through the 3.8 likelihood ratio, we end up with a 0.8 probability or 80% probability the child was abused. If we start with a much lower probability of abuse based on the fact that there's no history of abuse, start with 0.2, we end up with a 50% probability. Well, what does all that mean? It means that because the entire case depended on how accurate the test of just finding ICH and retinal hemorrhage was for abuse, we had to know how often it was wrong. So if we use the 50% probability, the most conservative basis, that 20% of the time this guy is going to be innocent, which is actually a very high probability of innocence for somebody who is going to be convicted based on the concept of what is true beyond a reasonable doubt. In a court case like this, you would have to be able to give testimony above 95% that this finding was equivalent to abuse. Fortunately, we were able to convince the prosecutor that that was the case, and they finally dismissed the case against this poor guy. It took a lot of explaining to get there, though. Here is another application of forensic epidemiology, which is a completely different way to go. This was a teenager, 17-year-old young man, described as a Boy Scout. I don't know if you have Boy Scouts in Indonesia or not, but basically they're really good kids. This boy was a Boy Scout, an Eagle Scout. Didn't have any problems, no issues, no girlfriend problems or anything like that. Happy kid. He was on scholarship to go to college. He goes to his, so no risk factors for suicide, goes to his pediatrician for a complaint of, just had a pain in his hand and a sinus infection, and he gets a prescription for an antibiotic and a anti-inflammatory, ketorolac. The pharmacy dispenses a drug called isosorbide mononitrate, which is like nitroglycerin, if you will. If you're familiar with that use, it's like that. It's a nitrate that is used to treat angina. So to treat pain due to coronary artery disease. This is not something that you're going to find in a 17-year-old boy. He, of course, had no idea what he was taking, and about 29 hours after taking this first dose, he shot himself with his hunting rifle in his parents' bedroom. A horrible, horrible case. And the question was, did it have anything to do with this drug that was misdispensed? I mean, that was the one thing that we knew was unusual about the situation. So causation of psychiatric outcomes is a bit different than easily observed outcomes like a gunshot wound or a stabbing or even a shaken baby syndrome. This is when there is an action that's associated with a psychiatric illness, for example. So, for example, homicides or assaults, suicides that occur, but there's some sort of a trigger that serves to sort of potentiate the action. So suicide, as I'm sure you all know, is multifactorial. There's a lot of reasons why people commit suicide. When it comes to teen suicide, where there's so many other factors going on, it is, I call it multifactorial, many factors coming together. And there's lots of triggers that are present in the life of a teenager. But the causation question, it really comes down to an epidemiologic causation question, because the real question is, what's the chance of a suicide occurring but for the exposure to this harmful exposure? So what's the harmful exposure? Well, it's taking the drug. And so the question is, what's the risk of suicide given the harmful exposure versus the risk of suicide if the harmful exposure never happens? If this kid never takes this medicine, what's the chance he kills himself 29 hours after taking this medicine? This ratio is called relative risk, and it gives an actual a quantification of causal probability. So epidemiology has made its way into injury causation in the US. Normally, epidemiology is used to assess causation in courts for issues like smoking and lung cancer. Did this person smoking cause their lung cancer is only going to be answered by epidemiologic study, but did this person get their injury as a result of an exposure of a traffic crash or a fall or a shaking or whatever it is? That's something that really epidemiology hasn't made its way into. But in recent years, 2016, there has been a decision at the highest level of court in the country that talks about a three-step process of evaluating injury causation that now incorporates epidemiologic methods. I'm very happy to say that the cited literature for it was actually a paper that I had published in 2009. So that made its way into case law in the United States, where we can talk about a systematic way to evaluate cause and effect relationships when there has been an injury. So it starts, the method starts with looking at the plausibility, the reasonableness that an exposure can cause an injury. That's the risk of the injury given the event. And then looks more specifically at the circumstances of the event and the individual by talking about the timing between the event, the exposure, and the outcome of injury. And then finally looking at whether or not it's more likely than not that the injury will be present if the exposure had never happened. So just put into a formulaic way, you can see it's the probability of the outcome, the O, given the exposure versus the probability of the outcome O given no exposure. That's the E with a line over it. So in this case, the question was, can this drug even cause suicidal behavior? What do we know about it? If it can, how often does that happen? So this just started out with a review of literature for suicidality amongst people who take this drug. Well, you're not going to find healthy teenagers who are given the drug. That's something we aren't going to see because that is would be misprescribed or misdispensed. We don't find mistakes that are studied with epidemiology typically because we try not to make mistakes. But we can look at these criteria. They're called Hill criteria, which are these a list of kind of causal checklist, if you will, that allows us to evaluate a cause and effect relationship. And I'll show you that a little bit more specifically in just a minute. So I did find one paper which talked about hallucinations and suicidal ideation due to this drug in an older person who was actually appropriately described the medicine. But that was the only evidence I found in the literature. So I had to go into a database and do a specific analysis of adverse events in a drug database. I use something called proportional reporting ratio. Not important to even know this, but it's a way that for me to explain to someone else who wants to do the same thing how to repeat what my methods were. I looked at all of the interactions described in the FDA's, the US FDA's adverse event reporting system database, where there was a suicidality, and I looked to see whether or not isosorbide mononitrate dinitrate, whether that drug was more often associated with suicidality than all of the other drugs combined. If you put them all together and look at how often suicidality was reported, what was that ratio between the isosorbide nitrates and all of the other drugs? And what I found was something no one's ever talked about before. This is one of the great things about this particular application of epidemiology, is that you get to look at completely unique questions that no one has addressed before, because you have to go out and get the data and do an analysis for a question that may never have been in the literature. So in this case, I found in this FDA database, it was 6.4 times more likely when you compare it to all of the drugs combined that the isosorbide nitrates will be associated with suicidality. I then went to something called the Naranja scale, which is a form of, I was talking about the Hill criteria. It's just this checklist to go through and see whether or not it's likely this drug was associated with this adverse reaction. And so you see that there are these various questions that come up, like, are there prior reports? Number one, did the adverse event appear after the drug was given? And there are a variety of various criteria that can be used. This is actually, you can use an online calculator, which is what I did, to come up with a score. And then the score actually gives me a result, which told me this was a probable adverse drug reaction, because I could say that there was a previous conclusive report. Yes, they gave me 1 point. Did the adverse event appear after the drug was given? Most certainly, they gave me 2 points. Was the drug detected in the body fluid in toxic concentrations? Yes, that was in the blood work that was performed at autopsy. And the final one was the adverse event confirmed by any objective evidence? Was a suicide? Of course it was. So I had enough information to say it's plausible. It makes sense. This drug could cause this reaction, except I just don't know how often that would be. I don't know if you gave 100 17-year-old boys this drug, I have no idea how often they would become suicidal. Simply isn't known. But not to despair. There are other ways to examine this relationship as well. A very important factor in this case was the close temporal association between the introduction of the drug to a completely healthy kid and his suicide 29 hours later. Because it was temporally proximate, we can use that proximity in a way of squeezing out other explanations. So this concept of temporal proximity is really important to understand in causal determinations. If I show you an example here of the red ball hitting the blue ball, and I say, did the red ball cause the blue ball to move? Well, you see a red ball move across the screen, it hits the blue ball, and the blue ball moves away. You're probably going to say, yeah, I think the red ball caused the blue ball to move. If I give you something a little different, where the red ball hits the blue ball and it takes a little while to move, you say, I'm not so sure. That doesn't look quite so consistent with what I know about the physics of one ball hitting another one. And then if I show you one where the ball just sits there and then takes off later, you'll say, no, the red ball didn't cause the blue ball to move. Now, what was important there was temporal proximity. It's also very instructive to look at that example and understand that the red ball did not cause the blue ball to move in any of the animations because it was an animation. There is no red ball. There is no blue ball. These are two colored discs that I found on the internet, and that I made one move, stop, and then made the other one move away. Remember what I said in the beginning of the talk? You can't see a cause. You can only infer a cause. I didn't see the red ball make the blue ball move. I saw the red ball hit what looked like hit the blue ball and saw it move away. And I drew the inference that the red ball caused the blue ball to move, which is very important because that's why risk is an important metric when you're trying to figure out what's underneath what it is that you can see. The temporal factors in this case were proximity. We know that the actions occurred very shortly after the drug was taken. And we also knew that it was within a reasonable time to actually cause the effects. And we knew that from the literature on the concentrations of these drugs and how quickly they come up after the drug's been taken. So we're able to show that temporal proximity was present. Then the last thing we look at is alternative causes. Now, I can't tell you how likely it is that the drug made this kid suicidal, which we know he was, but we can assess the probability that the average 17-year-old kid is going to commit suicide, because that we have data on. If we just say the day before he took this drug, what was the chance he was going to kill himself? We can actually analyze that. We knew there were no competing risk factors for suicide, but if we put this kid in with every other kid, and every other kid in the United States does potentially have risk factors for suicide, and we look at what the frequency is for suicide, first of all, amongst kids his age, suicide amongst 15 to 19-year-olds by gender, male versus female. And then we look at gunshot incidents. We can actually look at what the frequency is. It's 9.3 per 100,000 kids will kill themselves by gunshot in a given year. Now remember, we're not interested in a whole year. We're only interested in 29 hours. That's the only time that we're interested in the competing probability this kid was going to kill himself had he not taken the drug. So we end up with a frequency of 1 in 10,753 gunshot suicides per year. But that works out to around 1 in 2 million per day. So that's the really important thing, is that we now actually look at the cumulative risk, not for a year, taking it down to 1/365th of that. Now, we've got a kid who doesn't have any social personality, any factors that put him into anything other than the lowest 10% of risk, let's say, which would, let's say, put him at less than 1 in 20 million per day. And we look at it in the context of knowing there were only 11 million boys his age group in the entire United States in the given year. In other words, it's less than one death in the entire population in the entire United States for the lowest 10% of risk factors. So the fact that I couldn't come up with a numerator risk was not a barrier to completing a causal analysis, because I could say 1 in 2 million, 1 in 20 million, the chance that any other cause other than the misdispensed drug is virtually can be ignored in a causation analysis. The only known cause of the suicide was the exposure to the misdispensed drug. And this paper, this case, as a lot of my cases end up doing, got turned into a case study that was published last year, this year. I don't know when it came out, within the last year or so.
This year, Michael.
Was it this year? Thank you.
Yeah, 2 months ago, I think.
How long ago?
2 or 3 months ago. Seems like a lifetime ago this year, but
wow,
it wasn't that long ago.
What COVID has done to time. All right, let's
Michael?
talk about some. Yes.
Sorry, you have around like 10 more minutes for the presentation, and then we'll move on to the discussion. So maybe we could cover some more important points, and then we'll discuss more when we move on to the question and answers.
Okay, well, I've given you guys a lot of sort of heavy information. Let me let's get into, given the fact I've got 10 more minutes, let me do this. Hold on, let me just pick my slides for a minute.
10 minutes for the presentation, but we have around half an hour or so for the discussion.
Okay, no worries. Yeah. So I'm going to skip over the excited delirium analysis then, because that requires some explanation.
We will also provide the audience with the slides later on, so don't worry about missing out on stuff. And any questions can be posted in the chat column, and I will read it later on.
Okay, so let's see here. Give me just a second. I'll get this back up. So we'll skip the filling of the sandwich and move on to the bread on the other side. I'm going to talk about my last two cases, which are both investigations that are a little bit more sexy than what I've been talking about, if you will, because they're sort of interesting in their own right and rather unusual. So this was a case of a man who sustained a very serious head injury. He was in this car that went off the road. This was a case that occurred in Canada. And he was in the front passenger seat of this vehicle, which, as you can see, didn't sustain a whole lot of damage, but you can also see that the airbags went off in the vehicle. So the vehicle sustained enough of an impact to cause the airbags to deploy, but did not sustain a whole lot of crush to the front of it. What you see in the front of the vehicle looks like probably the kind of starring that you see when somebody hits their head on a windshield. So that's fairly typical in these kinds of crashes. And you can actually see in this picture here, you can see a little bit of blood inside here that is on the console in the center in between the seats. And there's a little better picture of it. This man sustained a very serious head injury called the diffuse axonal injury, where he had a shearing injury of the neurons throughout his brain. And it produced a very serious injury. He was in a coma for multiples of days and came out with a very serious incapacitation. You can see this large scar on the back of his head. And this is a CT scan of his head. And what you can see over here on the left side of his head is an enormous tear in his scalp and all this swelling and bleeding that had occurred. Diffuse axonal injury, you can see here in an autopsy slide, where there's all this sort of scarring, and it's diffuse, meaning that it's in both hemispheres of the brain in the white matter. Now, what happened in this case was this man was a passenger in the car. It was actually his car, but someone else was driving. Car goes off the road. He has this injury. They find him with all this blood. He has this very terrible injury. And he filed a claim with, in this case, it was the Canadian insurer for his injuries. The insurer hired a number of experts, and the experts came up with some very interesting theories about how he actually got his injury. So the plaintiff, these were attorneys who were representing this man, said, look, this guy obviously was injured in the crash. We're not sure how. He got an injury to the back of his head, and it was a frontal crash, and you see the windshield. We're not sure what happened, but obviously it happened in the crash. The defense really went overboard. They said, first of all, the injury to the back of his head is impossible. It didn't happen. The crash wasn't big enough to have caused his brain injury, and therefore, we think that the brain injury didn't happen in the crash, and there's not enough blood in the car for the size of this wound because it would have bled a lot. So we think he got the injury outside of the car, and even better yet, we think, and this was very special, because the man was from Southeast Asia, that he must have been in some sort of a ninja fight. You guys know what ninjas are? You know, guys in the black pajamas running around with swords? Right.
Yep.
It was a ninja fight with a sword, and that's what caused the injury. And that it didn't have anything to do with the car crash. They must have put him in the car, and then they crashed the car. This is a true story. This brings about this gentleman, Sherlock Holmes. I'm sure you all know about Sherlock Holmes. He very famously said that when you've eliminated the impossible, whatever remains, however improbable, must be the truth. I maintain that there is a fallacy associated with this, which says just because you think something is impossible doesn't necessarily mean that it is. And if you make up a Mickey Mouse story like this one, we're going to be able to actually demonstrate that it's not true. So I went through systematically and looked at the claims that came from these folks, where they came through a forensic pathologist and a very famous neurosurgeon testified in the case. The first claim, which was that there wasn't enough blood in the car, was a very easy one. The pathologist who made this claim used this photograph to state that there wasn't enough blood for the injury in the car. But this was the car at the time the photograph was taken, and I think you can see that it's missing something like a door. The car was actually exposed to the elements for about 2 years before the photograph was taken. What happens to blood when it's exposed to the elements? It degrades. So this is actually what the blood looked like 2 years after this vehicle had been exposed to the elements. But this is what it looks like at the time of the crash. And what you can see, hopefully, is that the entire seat is covered in blood. Everything has got blood all over it. And that this man actually did bleed quite a bit in the car. The expert who said you can't get a diffuse axonal injury in this crash basically said this based on his experience, an idiosyncratic piece of evidence. In order to analyze this, I went to National Crash Injury Data. That's what this NAS CDS is. I looked at every case of diffuse axonal injury that was reported, and I looked at the speeds of the crashes. And what I was able to show was that there was about a 1 in 105 chance of this injury at 9 miles per hour, but that it was not impossible. But here was the real kicker, was that there was no mechanism to produce this injury at the back of the head in this low speed crash, and therefore it must have been an assault. Part of that evidence was looking at this mark on the man's chest, which the pathologist said must have been from a boot. So these were ninjas who wear boots, apparently, and after they hit their opponents with swords, they then step on them. I have no idea where they came up with that. But if you look at the actual evidence on the vehicle, you'll see that the windshield is bulged out, as is the header right above it. So the part of the roof that is attached to the windshield is bowed upwards. And if you look inside the vehicle, what do you see? You see what's called a witness mark. This area right here has obviously had an impact. And if you pull back the bodywork, the interior work rather, where the impact was, what you see right here is hair. That tells us this man sustained a very large impact to a part of his head that had hair on it. Well, how did that happen? He was not wearing a seatbelt. The vehicle went off the road and then went down, which would have allowed him to basically separate from a seatbelt and move forward as the vehicle moved into the shrubs. And then the airbag deployed. Well, what happens when an airbag deploys? If you are above the airbag, as this man very well probably was, then the passenger airbag, as you can see, comes out and up. And if he was over it and above it, it would have thrown him up into the header so that the back of his head actually could impact the top of the roof, and he could cause the injury to the back of his head. And you actually will see that if we look at his face on the CT scan, that he's got swelling on the right side of his face, and he's got the tear on the left side of his head. And those two things match, so that his head was rotated slightly to the right at the point of impact. Slightly to the left at the point of impact, because it's it's the right side. I'm sorry. It is, so his head was rotated to the right. He would have impacted the airbag with the right cheek, and then would have had the tear on the left side of his head. And I think I'm pointing at the wrong part of my face. So basically, if we go back to Holmes' maxim, we ask, what is it that deformed the windshield header upwards if it wasn't the passenger's head? There was nothing else that actually could have caused that damage. So when choosing between explanation, let's go with improbable as opposed to really absurd or ridiculous ones. So here's the last one I want to show you. This is pretty quick. This is something that we don't think of very often, but it actually occurs more often than you might think is occurring, which is falls of neonates while in the hospital. This is a baby who's been placed on a warmer, on a little cart that's being pulled through a door. And I'm going to play this video that you're going to see from surveillance as this cart actually stops and the baby is pulled out onto the ground and then scooped up quickly. And it's really hard to see, but what you'll see is, as this is the neonatologist here on the left, she is walking backwards and she's got her hands on the baby, and the cart stops and she continues to go backwards. And you see there's the baby falling. You can see his little head with his cap on. He gets all the way down and hits the ground, and then scooped up like a 5-second rule and put back in the cart. So we don't always have this kind of evidence where we can see it on video what happened. This is a case in which, a different case, not the one I just showed you the video of, in which a baby was born by cesarean and was completely healthy, was taken away to the NICU, or the nursery rather, and brought back the next day with a skull fracture, an intracranial hemorrhage, and a stroke. Nobody said anything about the baby having fallen, but the obstetrician said that baby did not have a skull fracture and was delivered. The plaintiff had a theory that the baby was dropped by the hospital staff, and the hospital staff said, "No, he must have gotten a skull fracture during the birth process." So this came down to a risk question, and that is, if we find a skull fracture in a baby who has had a C-section, can that actually serve as such a high proxy for fall that we can say it equates to a fall. It's just like seeing the guy with the bullet wound to the head. Can we say that that's the most likely thing that killed him because nothing else is going to be as likely? So I did an analysis of national crash injury data in which I looked at all C-section births in which there was a fracture. This is hospital data again. And I looked at all C-section births where there was not a fracture. And then I broke them up into those with a history of trauma and looked at the ratios, and then looked at those with a history of a fall and then made a comparison. And what I came up with, I used almost 2.7 million births. I had 47 C-sections with fracture, and of course all the other births without fracture. And what it turned out was that 87% of the C-sections with a fracture had an external trauma, and 80% of them were falls, which made it 7,000 times more likely that a child who has a C-section and has a fracture has had a fall than if the child doesn't have the fracture. And therefore, like the shaken baby syndrome, where we were talking about the presence of subdural hemorrhage, intracranial hemorrhage as a proxy for abuse, in this case, I actually could use the fracture as a proxy for abuse. And in that case, they finally actually admitted that the child had a fall. I think you've got all my references in the slides that I sent you. I won't worry about that. And we can move on to questions. Thank you for bearing with me through that. It's a little bit difficult in this format, but I appreciate you letting me get through some of my stories and cases.
All right, thank you, Michael, Prof. Freeman, for your very, very comprehensive and informative presentation. And I don't know whether Harry is here also to join us, but I don't know if he is already ready to say hi to you. So we will continue with questions first. So let me just pull up the questions. So the first question is from Dr. Sani, one of my colleagues from Bandung, Indonesia. You have to visit there one time. So, yeah. So the question is, can LR and RR be applied globally, or do they vary in different populations? That's the first question. Did you get that?
I did. They need to be very population specific. So when you're using a relative risk, for example, when I talked about one crash having a 10 times greater risk of causing a fracture than another type of crash, we have to be very specific about the type of crash. So that is a more in-depth analysis that makes sure that the predictive characteristics that match the case you're investigating are adequately controlled for in the analysis that you do. So generally the answer is yes, that when you're doing an analysis to talk about what the most likely cause is, you want to try to match as closely to the circumstances as you can of the actual circumstances versus the alternative circumstances. When you were talking about a LR, the likelihood ratio analysis, like we were talking about for shaken baby syndrome, it's a little bit different because in that case, I'm trying to understand how good the test is that somebody else used to say, I know this baby was abused. And they're not saying, oh, well, I took into account the fact that the child had coagulopathy. I took into account the fact that the child had no other signs of trauma. They didn't do that. They just said, if I find intracranial hemorrhage, it's abuse. And so I was more specific in my analysis, but it's very appropriate to put the test to such assertions when they are essentially myths rather than evidence-based methods.
So I think that the likelihood ratio at RR should be population specific. I think that's your point. So
yes.
that You need to have specific data from which the population was taken, from which the victim came from. So this is the one of the special traits of forensic epidemiology, I think. Yeah.
I agree.
Yeah. Okay. The second question, still from Sunny, is how do we take into account any confounding factors or other risk factors that then affect the outcome?
Well, a confounding factor is one that produces an effect that you can't, that's sort of hidden. It's a good example for it would be if you look at people who take anti-inflammatory medication, they are much more likely to have arthritis versus people who don't take anti-inflammatory medication. There's an issue with the cause and effect relationship, but ignore that for right now. But if you put everybody together in the population and you say, I'm going to look at everybody who takes the medicine and everybody doesn't take the medicine, you'll find a lot more arthritis than people who take the medicine. That is a confounding factor because the medicine doesn't cause the arthritis. You control for that by saying, I'm going to look at how old the people are who don't take the medicine and look at how old people are who do take the medicine. And I'm going to try to match them because all the people who don't take the medicine are younger, obviously. They're less likely to have arthritis. So if we match based on age, we control for that confounder of age contributing to arthritis. And then we can see whether or not people the same age who take medicine are more likely to have arthritis. It's a similar kind of idea. The closer you get to the population of interest, the more you cut out confounding factors. And so the example that I gave of the coagulopathy population who actually had a higher rate of abuse versus the population who didn't have coagulopathy, they had an excess rate of like 9% more of abuse determinations. That may actually be a factor that because it's not a confounded population, we separated by coagulopathy, that we could actually see the real differences between the groups, and we may be able to draw other inferences from that. If you combine the two, then you may end up with problems in your final conclusions because you combined everybody. So dividing them gets rid of the confounder. So again, I think it goes back to the first question, which is be as population as specific as you can when you're doing the analysis.
Okay, thank you, Michael. Sunny, if anything is still not clear, you can follow up question in the chat column. Meanwhile, we have Prof. Herkutanto here. Harry, Prof. Herkutanto, maybe you would like to say hi to Prof. Freeman and also give some comments or questions. Go ahead.
Hi, Michael. Nice
Harry,
to meet you. Nice to see you.
Nice to see you too.
Yes, and well, thank you for your quite thought-provoking lectures. And frankly, this is for the first time for us in Indonesia. We are introduced with the forensic epidemiology. Well, and back to the first question is, can one country use another country's data of a set of facts, like the risk of causation according to something is like this and could be applied to another country? Yes, or that every country should create their own specific data. Thank you, Michael.
That's a great question. Well, I would say it depends. For example, in Indonesia, I know that you had an outbreak of epidural-related deaths, people who died after getting epidurals. which occurred a few years back. And that was investigated by the national health authorities and other folks. And this is something that Putri and I have talked about quite a bit. I can't use American data to look at how epidurals are applied and the kind of medicines that are used, because the medicines may be different. The circumstances under which epidurals are used may be very, very different. We, in the US, we have a very much a system that is not driven by need as much as want in some cases. And so what occurs during epidurals may be very, very different than in Indonesia. However, if we were talking about something like a car crash at very high speed, so a 100-kilometer car crash into a tree, and somebody is not wearing a seatbelt, and we say, what would have happened if they would have been wearing a seatbelt? It's a simple question. Those data should be the same. I mean, if somebody, you know, it doesn't matter if you're from Indonesia or you're from the United States. If you fall off a cliff, it tends to be bad for you. If you're in a big high-speed car crash and not wearing a seatbelt, that's going to have about the same effect. So it really depends on the exposure that we're talking about.
Well, is there any effort left to minimize the local specificity for each population? If we want to, well, compare between the cause of accident in the US or in Indonesia, yeah. I think there is a local specificity that doesn't occur in another country. Is there any effort from epidemiologist's point of view to reduce that kind of factors?
Well, I can't say that there are ongoing efforts, but I think, very frankly, that the kind of international collaboration that we're doing between the US, Europe, Indonesia, and we have students in Canada, and we'll have students in Europe. We put all of that together and we work as a network. And so then we have local specialists like you and Putri, and then but we combine our
data
experience, and we combine our data. Exactly.
Oh yes, yes. Well, that it is a good initiative. How can we pull a big data from all of the country from us? Can we make maybe like a consortium of the trauma of, maybe we can, it would be beneficial for all of us. Thank you, Michael.
Thank you.
Okay.
Back to Putri.
Yeah, thank you, Prof. Herkutanto. Michael, I have to tell you that forensic epidemiology is quite new, and maybe Prof. Herkutanto and I, and also a couple of colleagues, are the only ones in Indonesia who know about it at this moment. So here we have a lot of homework to do. And thank you very much for your very eye-opening and this lecture today about the broader scope of forensic medicine and the application of forensic epidemiology, and a lot of case types. And because of the time constraints, I'm going to summarize a bit, if you don't mind, from today's discussion. So the first point is that forensic epidemiology is the application of epidemiologic data and methods in forensic investigations. So there's a broad variety of cases in which we can apply it, not only injury, but also toxicology, for example, medical negligence, and so on. And causation is the crux of any forensic investigation, be it simple cases, and even more so in complex cases in which there are multifactorial potential causes. So I know a lot of you are thinking, wow, that's a lot of numbers and a lot of math and formulae, but don't be deterred by that, because the main point of forensic epidemiology is just you have to focus on the principles and especially on causal analysis, which is, I think, what we do every day in forensic medicine and also in medicine in general. So again, thank you, Prof. Freeman. And I'd also like to thank all attendees for joining today, and to the organizing committee from the doctoral program in medical sciences, Faculty of Medicine, University of Indonesia. That's all for me. Wassalamualaikum warahmatullahi wabarakatuh. Good day to all. Stay safe, healthy, and happy. Back to you, Dr. Erna.
Thank you, Dr. Putri. All right, we are in the end of this program. Thank you again for Professor Freeman for your interesting lecture. Before we close this event, we will take the second paragraph. To all participants, Professor, Doctor, please turn your video camera on. All right, Pak Yana, please take the picture.
Okay. 1, 2, 3. Once again, please. 1, 2, 3. Okay, thank you.
Thank you, Professor Freeman. To all participants and committee, we hope this lecture will provide good benefit for all of us. Sorry if there is any mistakes.